All right. Well, hello, everyone. I'm David Walker, and I'm coming to you from Chicago at the American College of Healthcare Executives. But I want to thank Dr. Codell and Dr. Um, Casey and others for allowing me to supervise a psychiatry resident each year. And this current academic year, I've had the privilege of supervising and working with Dr. Bhargavi, and I want to thank her. uh, she originally from India and now from Orland Park, Illinois. She did her undergraduate in integrative biology at the University of Illinois at Urbana-Champaign and medical school at Rosalind Franklin University in North Chicago. Her interests involve what this topic is going to be on: treatment of substance use disorders, treatment of res- treatment-resistant depression, and women's health. And right now she's looking at doing locums, although I've been trying to talk her into working for the VA. I haven't had success there, but certainly success, and really have enjoyed working with her this year. So with that, I'll hand it over and I look forward to the presentation.
Okay, hello. I'm Bhargavi Ancha. So I'm a fourth year psychiatry resident for those who don't know me. So today my grand rounds presentation will be on opioid use disorder in pregnancy. To start off, I have no financial disclosures. So the objectives of today's grand rounds is to identify our patient population and barriers to care, understanding medication selection for opioid use disorder, evaluating the need to change medication during pregnancy, dose changes in pregnancy, comparing maternal and fetal outcomes on different medications, as well as discussing longer-term neurodevelopmental outcomes. So I think this is especially important because the Mainstreaming Addiction Treatment Act was passed in December 2022. So this act has eliminated the data waiver, which is also known as the X waiver program. So what that means is that all DEA registered practitioners with Schedule III authority may prescribe buprenorphine for opioid use disorder if permitted by state law. And now there are no limit to the number of patients with opioid use disorder that a practitioner can treat with buprenorphine. I feel that this is especially important because 40% of counties in the United States did not have anyone registered to prescribe buprenorphine prior to the passage of this act. So a little bit more about the history. So first and foremost, opioid use disorder is defined as the problematic use of opioids that causes significant impairment or distress. In the 1990s, there was increased attention to the undertreatment of chronic pain, and it became a national health campaign. Medical bodies started to push that pain is the fifth vital sign. Prescribers were guided to overtreat acute and chronic pain. There was also aggressive and deceptive marketing of opioid pain medications, particularly OxyContin, a long-acting extended release formulation. Manufacturers at the time were saying that it was, you were less likely to become dependent on it because it was an extended release formulation. And they later went to court and went bankrupt and all sorts of issues happened. In October 2017, the opioid crisis was declared a public health emergency. So looking at the numbers, in 2012, 2.1 million people in the US had substance use disorders related to prescription opioids, and 476,000 were dependent on heroin. In 2012, over 80,000 drug overdose deaths involved an opioid. From 1999 to 2021, the number of opioid overdoses increased tenfold. Looking specifically at pregnancy, as of 2017, 8.2 of 1,000 deliveries were affected by opioid use/misuse. Medicaid recipients had 14 of 1,000 deliveries affected by opioid use/misuse. Per the CDC, the prevalence of opioid use disorder in pregnancy has increased by 333% from 1999 to 2014. So per the CDC, there are 3 waves of opioid overdose deaths. So the first wave started in the 1990s with a rise in prescription opioids. Um, and then the second wave, which is in dark blue, was the rise in heroin overdose deaths, which started in 2010. And although overdose deaths were increasing, they seem to fluctuate and were relatively stable from 1999 to the early 2010s. With the third wave, there was a rise in synthetic opioid overdose deaths, which started in 2013, specifically fentanyl. Fentanyl was mixed in with heroin, counterfeit pills, cocaine, and you can see in the dark purple, the overdose deaths increased exponentially. And as of 2021, overdose deaths from any opioid was about 25 per 100,000. So I did want to bring up terminology, just because opioid use disorder, as well as substance use disorders in general, do carry a negative stigma, and it can be detrimental for the patient to experience wording that may make them feel shameful, make them doubt themselves, and less likely to seek treatment. So first and foremost, instead of using words like addict, user, junkie, I think we all know we should probably stay away from those words. We can say person with substance use disorder, mainly because we don't want a person's substance use disorder to be the primary characteristic of them. They are more than just their substance use disorder. So our goal is to be as medically accurate as we can while removing what stigma we can remove. Instead of saying former addict, you can say a person in recovery. Instead of saying habit, you can say substance use disorder, particularly because habit makes it appear that it's more of a choice than anything, and can also minimize a substance use disorder. A habit is going to the gym after work, not using illicit substances, basically. Instead of saying abuse for illicit drugs, we can say use, whereas for prescription medications, we can say misuse, as you are supposed to use your prescription medications, but when you take more than prescribed or use it incorrectly, then it's termed as misuse. Instead of saying dirty, if we're referring to toxicology screens, you can say testing positive, or if you're talking about where they are in terms of their substance use disorder, you can say person who uses drugs. So instead of saying clean, if you're referring to toxicology screens, once again, you can say testing negative. If you're referring to where they are in terms of their substance use disorder, you can say recovery or remission, or even abstinent from drugs. Instead of using the word relapse, we use the word return to use. Instead of saying addicted baby, we can say baby with neonatal abstinence syndrome or neonatal opioid withdrawal syndrome, because saying addicted baby, that brings up stigma once again. The baby is not the one with an active substance use disorder and is receiving or is having withdrawal symptoms from the substance. And something interesting was that they are now transitioning away from using the word medication-assisted treatment and are now using medication for opioid use disorder, which is what I will refer to, basically medication for opioid use disorder, mainly because medication-assisted treatment, it implies that medication might be temporary, and that medication might be temporary, as well as not being on medication is a viable option. Okay, so going a little bit more into terminology. So this is more medical. So for opiate, it is extracted from natural plant matter. For example, opium, morphine, codeine, and heroin. Opioid, on the other hand, is not derived from natural plant matter. mostly synthesized in a lab. For example, hydrocodone, oxycodone, fentanyl, buprenorphine, methadone. So generally in the medical community, it's used pretty interchangeably. The main difference is that when you are ordering a urine drug test, opiates are what you are testing for, specifically derivatives of morphine and 6-acetylmorphine. Whereas if you're trying to see if someone is compliant or using buprenorphine or methadone, you're going to have to order that separately. Next, neonatal abstinence syndrome. So it is a clinical manifestation seen in neonates due to withdrawal from intrauterine drug exposure. So, and then furthermore, neonatal opioid withdrawal syndrome. It is neonatal drug withdrawal from intrauterine opioid exposure. So the main difference is that neonatal abstinence syndrome, it is nonspecific and it can refer to a constellation of symptoms seen withdrawing from any substance. Now we're turning more towards neonatal opioid withdrawal syndrome because it's more specific. And these syndromes, they generally appear once the baby has been delivered, but they can be present for up to 28 days after birth. Okay, so how do we diagnose opioid use disorder? So per the DSM-5 diagnostic criteria, you must have 2 within the past 12 months. So 1, opioids taken in larger amounts or longer duration than intended. 2, persistent desire to cut down or control use. 3, large amount of time spent using, obtaining, or recovering from opioids. 4, persistent desire to use opioids. 5, use interferes with important obligations at school, work, or home. 6, continued use despite social or interpersonal problems related to opioids. 7, social, recreational, or occupational activities given up due to opioid use. 8, recurrent use in hazardous situations. 9, continued use despite recurrent physical or psychological problem likely caused or exacerbated by opioid use. And then tolerance and withdrawal. Okay, so why do we care? What are the risks of having opioid use disorder? So you can be at increased risk of early death, usually via overdose, trauma, suicide, or infectious disease such as hepatitis C and HIV. There can be increased legal problems due to high impulsivity and criminality of illicit substances. There are also significant psychosocial concerns regarding unemployment, low income, food security, and lacking transportation. And especially as psychiatrists, there is an increased prevalence of depression, anxiety, and PTSD in this population. Specifically in terms of pregnancy, there can be preterm labor, which means delivery before the 37th week of gestation, fetal death, growth restriction, which means less than 10 percentile for fetal weight, as well as neonatal opioid withdrawal syndrome. So how do we screen for patients? So we should generally screen at the initial visit and at least every trimester for those who screen positive for past use. If you're seeing a patient more frequently than that, you should probably screen at every appointment. The role of toxicology screens is unclear prior to committing for medication for opioid use disorder. Some recommend ordering testing, while others recommend screening via questionnaire versus a urine drug screen, as the topic should be discussed in a non-judgmental manner due to the stigma of using substances. So a quick screen that I found was the 4 Ps, where they focus on the parents, partner, past, and the current pregnancy. So basically, did either of your parents have a problem with alcohol or drugs? Does your partner have a problem with alcohol or drugs? Before you became pregnant, did you have a problem with alcohol or drugs? And in the past month, did you drink beer, wine, liquor, or use drugs? So during assessment, we should really be looking at the specifics of patient's substance use disorder, underlying comorbid disease or conditions, the effects of opioid use on the patient's mental and physical functioning, and the outcomes of any previous substance use treatment, as well as legal concerns over social services and child abuse. Motivational interviewing is a great way to encourage positive change. So first and foremost, expressing empathy, trying to discuss the substance use disorder, not being judgmental, just practicing your active listening, avoiding argumentation. So you don't want to seem like an authoritarian talking down to patients regarding their substance use disorder, because chances are that they know that it's not the best for them. Rolling with resistance. So if you do have some pushback, know when to give, but also know when to push. Develop discrepancy. So, talk about what the patient wants for their future and see if their current behaviors are aligning with the outcome that they want. And also support self-efficacy. So really encourage them, give them the confidence that they can do this, that they can make the changes needed. In terms of further testing, routine HIV, hepatitis B and C, and STI testing are also appropriate. This is often ordered by the OB-GYN, but can be ordered if there is a concern of lack of follow-up, especially because women with opioid use disorder may not receive adequate prenatal care due to fear of incarceration for using illicit substances and exposing the fetus to illicit substances, as well as losing custody of other children. So in terms of medication, most professional bodies recommend medication for opioid use disorder as a first-line treatment because there are concerns of relapse and dropout from treatment with detoxification. The goal is to maintain dosage high enough to prevent withdrawal symptoms and relapse, yet low enough to prevent euphoria. Okay, and in terms of substance use disorders, we always do have to talk about return to use. So opioid use disorder is a chronic condition, and return to use episodes can occur especially during the initiation of treatment and when the patient is acquiring coping skills. It should not be viewed as a failure or setback, and it indicates a need to reassess that patient and adjust the treatment plan. So the FDA-approved treatments for opioid use disorder are buprenorphine, methadone, and naltrexone. And in terms of buprenorphine, it also includes the combination buprenorphine naloxone. So what are the benefits of medication? So it creates a stable intrauterine environment as it prevents cyclical withdrawal of short-acting opioids, because if mother is in active substance use, those cycles of intoxication and withdrawal can lead to increased corticosteroids, vasoconstriction, and possibly fetal demise. Another benefit is prevention of cravings and withdrawal, and treatment with medication for opioid use disorder, increased adherence to prenatal care, decreased incidence of preterm birth, reduction in relapse, decrease in opioid overdose, and death subsequent to overdose. To start off with buprenorphine, so it is a high affinity partial agonist at the mu-opioid receptors with low intrinsic activity. It can be prescribed by providers with DEA registration and 8 hours of training. The buprenorphine dropout rate is significantly higher than methadone, although dropout rates are similar after 50 days. And as a full mu-opioid agonist, a full mu-opioid agonist will induce withdrawal symptoms, so the patient should be exhibiting withdrawal symptoms prior to their first dose. Methadone is a full agonist with high intrinsic activity at mu-opioid receptors. It is administered during in-person daily or near daily appointments at federally regulated treatment programs. It can take days to weeks to reach a stable dose. And methadone does not have a ceiling effect, and there is a greater risk of overdose. Naltrexone is a pure opioid antagonist with high affinity for the mu-opioid receptor. It blocks euphoria secondary to opioid agonists, does not have abuse potential and tolerance, and has limited side effects. Any licensed physician or practitioner can prescribe this medication. and it is also FDA approved for alcohol use disorder. So all of these medications are in the FDA category C for pregnancy. So what that means is that animal reproduction studies have shown an adverse effect on the fetus, and there are no adequate and well-controlled studies in humans, but potential benefits may warrant use of the drug in pregnant women despite potential risks. So let's look at the data comparing buprenorphine versus methadone. So a lot of studies in this field, they can be small, some are underpowered, but there have been higher quality studies that have come out in the past few years. So this is probably one of the better ones that I found. So this was published in the New England Journal of Medicine in 2022. So it's a cohort study of pregnant women on public insurance programs in the US from 2000 to 2018. In a database of 2.5 million pregnancies, they found over 31,000 participants were included in the study. So the groups were exposure to buprenorphine versus methadone, and it was assessed in early pregnancy, late pregnancy, and 30 days before delivery. So basically, the outcome of the study was that buprenorphine had lower risk of adverse neonatal outcomes than methadone. So they had decreased incidence of neonatal opioid withdrawal syndrome, preterm birth, small size for gestational age, and low birth weight. The results of exposure in early pregnancy was consistent with exposure in late pregnancy. So the outcomes were similar whether they were exposed early or late. And there is no significant difference in adverse maternal outcomes, which include C-section, as well as other severe maternal complications. In terms of further research, this was another study. It had 3 randomized controlled trials as well as 15 observational studies. So they found that buprenorphine was associated with lower risk of preterm birth, greater birth weight, and larger head circumference compared to methadone. They also found no difference for spontaneous fetal death, fetal and congenital abnormalities, and other fetal growth measures. The buprenorphine group had increased prenatal care compliance during pregnancy, shorter infant hospital stay, and lower rate of NICU admissions compared to the methadone group. So other considerations when deciding whether to pick buprenorphine versus methadone would be the severity of dependence. So buprenorphine is a lot easier to administer. Generally, it's monthly appointments, whereas methadone is near daily appointments. So more likely than not, the patients on methadone have likely not responded to buprenorphine. So there is a consideration that that might play a role. And also risk of divergence. For buprenorphine, once again, it's once monthly appointments usually, whereas for methadone, it's near daily appointments. So you do have a lower risk of divergence with methadone. In terms of withdrawal symptoms, you are more likely to have withdrawal symptoms with buprenorphine as it is a partial agonist versus methadone is a full agonist. So you are less likely to have withdrawal symptoms with methadone. Overdose risk is also a consideration. So buprenorphine has a ceiling effect, which means that once you increase past a certain dose, then the physiological effects plateau. Whereas with methadone, if you increase the dose, you will have increased physiologic effects. So you have a greater overdose risk with methadone. Methadone also has interactions with antiretroviral therapy for HIV/AIDS. So that is something to consider if you have a brand new patient and you are starting buprenorphine or methadone. So it might lead you to pick buprenorphine instead. Okay, so we talked about buprenorphine, but what about buprenorphine naloxone, which is commonly referred to as Suboxone? So in the literature, buprenorphine is generally preferred to buprenorphine naloxone to minimize risks of potential teratogenic side effects. The rationale is that it's better to expose the fetus to one medication instead of 2. Animal data suggests that fetal naloxone produces hormonal changes in mothers and subsequently the fetus. And a lot of this has to do with the HPA access, but the clinical significance is unclear. And naloxone use has generally been limited to maternal overdose. There is a concern that withdrawal will lead to fetal distress in preterm delivery. So looking at the data between buprenorphine naloxone exposure in pregnancy and no opioids during pregnancy, there was no significant difference in preterm delivery, birth weight, congenital anomalies, stillbirth, APGAR scores, and C-section rates. So there's increasing data to support buprenorphine naloxone as being safer in pregnancy than previously thought and may be an alternative to buprenorphine monotherapy. Moving on to naltrexone, there is a gap in information regarding the safety and efficacy in pregnant women. So looking at the data, naltrexone exposed neonates had superior outcomes compared to methadone exposed neonates in terms of birth weight, head circumference, length, neonatal opioid withdrawal syndrome rates, and length of hospital stay. Naltrexone exposed neonates also had lower rates of neonatal opioid withdrawal syndrome and length of hospital stay compared to buprenorphine exposed neonates. Otherwise, the outcomes were similar. So other things to consider when using naltrexone for or with pregnant women is that there needs to be a 7 to 10 day minimum period to abstain from opiates and opioids prior to initiation. And there's concern of fetal well-being during this period of detoxification. So what does that mean clinically? So it generally means that naltrexone treatment may be appropriate to continue for patients already taking it for opioid use disorder and who are also not interested in buprenorphine or methadone, but it is not a first-line agent in a pregnant woman interested in medication treatment. So basically, do we change medication during pregnancy? So the answer is not necessarily. So pregnancy alone is not an indication to change medication for opioid use disorder when stable. If the patient is having cravings and withdrawal symptoms, they should have their dosage reevaluated. And there is no general consensus regarding if a patient planning to become pregnant should be switched from buprenorphine naloxone to buprenorphine only. So based on the data, all of these medications appear to be relatively safe for the most part. It's just that there's more data to support buprenorphine versus buprenorphine naloxone. And they especially do not recommend, I guess, de-escalating medication. I wouldn't necessarily say that's the right word, but they don't recommend going from a full opioid agonist like methadone to a partial opioid agonist like buprenorphine if pregnancy is the only change. Okay, now going to medically supervised withdrawal. So it is generally not recommended and should be avoided if possible. Withdrawal is associated with higher rates of return to use episodes. Repeated cycles of intoxication and withdrawal are associated with fetal distress with sequelae including placental insufficiency, loss of pregnancy, intrauterine growth restriction, and preterm labor and birth. So it's really only considered when the patient requests it. The patient should be counseled on the high rate of return to use and the risk of overdose on mother and fetus. The patient can also be restarted on medication for opioid use disorder at any point if she is unable to tolerate detoxification or has a return to use episode. So dose adjustments during pregnancy. So there are dose adjustments involved for both methadone and buprenorphine. So methadone may need to be titrated upwards, especially in the 3rd trimester of pregnancy due to physiological changes associated with pregnancy. Progesterone increases during pregnancy and induces the cytochrome P450 systems, mainly 3A4 and 2D6. In pregnancy, especially the 3rd trimester, the volume of distribution, renal clearance, and the fetal-placental unit also increases methadone clearance rates. And just to put a number on it, they did study a sample of 4 patients where they found that the tromein methadone plasma concentration was 0.12 milligrams per liter in the 1st trimester and 0.07 milligrams per liter in the third trimester. So it looks like the dose was basically half the concentration in the third trimester. So split dosing of methadone may be helpful to manage metabolic changes in the third trimester of pregnancy. It is also important to note that postpartum methadone dose tapers can be challenging. In a sample of 12 patients, only 17% were able to decrease their postpartum dose, with an overall mean dose decrease of 12% at 6 months postpartum. So patients on buprenorphine also have a similar need for dose titration in the third trimester. Buprenorphine is metabolized by CYP3A4 as well, and there are no standardized approaches for increasing medication for opioid use disorder doses during pregnancy. So patients should be counseled on the possibility of increased cravings and withdrawal symptoms as the pregnancy progresses. So moving on to neonatal opioid withdrawal syndrome. So like we said earlier, it is a constellation of symptoms, signs that you see after birth up to 28 days after birth. And they include symptoms such as a high-pitched cry, hyperirritability, seizures, sleep deprivation, sleep fragmentation, tachypnea, hypertension, tachycardia, diarrhea, excessive weight loss, vomiting, sneezing, excessive suck, poor or excessive feeding, yawning, sweating, hyperthermia, hypertonia, and tremors. So I think this is especially important because looking at this graph on this figure, it says neonatal abstinence syndrome, but they specifically are referring to opioids. But if you see here, Kentucky is dark blue, so the incidence in 2012 to 2013 of neonatal opioid withdrawal syndrome was 10.1 to 30 cases per 1,000 hospital births, and it is significantly higher than the other states that were surveyed for this. The ones in black, which have the highest rates, are West Virginia, Maine, and Vermont. Okay, so in terms of neonatal opioid withdrawal syndrome, looking at buprenorphine versus methadone, in the literature, buprenorphine is associated with a lower risk of neonatal opioid withdrawal syndrome and a shorter duration of neonatal treatment than methadone. Methadone had a relative risk of 1.3 compared to buprenorphine. It is also notable that severe dependence is more common in those treated with methadone, so 77% versus 32%. And even when adjusting for severe dependence, methadone still had a relative rate of 1.2 compared to buprenorphine. In terms of naltrexone, so neonatal opioid withdrawal syndrome in neonates over 34 weeks was significantly lower in naltrexone versus buprenorphine or methadone. So it was about 8.4% versus 75.2% for the group of combined buprenorphine and methadone. Naltrexone-exposed neonates had significantly lower rate of neonatal opioid withdrawal syndrome and shorter length of hospitalization than buprenorphine and methadone-exposed infants. Okay, so looking at the dosage and how it affects neonatal opioid withdrawal syndrome. So there is no significant association between methadone or buprenorphine dosage and peak score, total morphine needed to treat the neonatal hospital stay duration, the number of pharmacologic treatment days, estimated gestational age at delivery, APGAR scores at 5 minutes, and neonatal head circumference, weight, and length. So moving on to breastfeeding. Breastfeeding is encouraged for mothers on methadone, buprenorphine, or naltrexone who abstain from illicit substances. Small, clinically insignificant amounts of methadone and buprenorphine pass into the breast milk, so it is less than 1%. And breastfeeding on methadone and buprenorphine decreases neonatal hospital length of stay and reduces neonatal opioid withdrawal syndrome severity and duration. And per the Academy of Breastfeeding Medicine clinical protocol, it is recommended to monitor infant for sedation and respiratory depression if methadone is initiated postpartum or being titrated over 100 milligrams. I think this is especially important because women with opioid use disorder and substance use disorders in general breastfeed less frequently than control groups without substance use disorders. So I think it's really important to highlight that, yes, they can safely breastfeed their baby because it provides not only the benefits we spoke about, but also immunity and other medical benefits. It also improves maternal-infant bond, maternal self-esteem, and is another motivator to encourage sobriety. So looking at the neurodevelopmental outcomes, research regarding neurodevelopmental outcomes has been limited. So they have found that strabismus, nystagmus, and impaired stereovision are twice as likely to be present in methadone-exposed children versus unexposed peers. So the top image is a child with strabismus of the left eye, and the bottom is what stereo vision might look like. So it just means that there's a misalignment of eyes. So the person has a hard time generating a stable 3D image. So that's what it might look like. And prenatal methadone exposure was associated with significant differences in visual evoked potentials, which indicates altered visual pathways. Mental development index scores of children with prenatal methadone had a mean difference of minus 4.3 compared to unexposed children at age 2. So it means that the methadone group scored 4.3 points lower than the unexposed group. Similarly, for the psychomotor development index scores, the methadone group scored 5.42 points less than the unexposed children. A meta-analysis of over 27 studies showed an overall negative association of exposure to methadone or buprenorphine with cognitive development. So it seems like there is data that indicates that there is this correlation, but it's multifactorial and there's a lot of other things that are going into play. So for example, cognitive testing in infants and young children have poor predictive value for later developmental delay. So just because the children in the methadone group and the buprenorphine group are scoring lower, it doesn't necessarily mean that there's going to be a developmental delay. There's also confounding factors, including tobacco exposure and socioeconomic status. Like I brought up at the beginning of the presentation, the number of children whose births are complicated by opioid use disorder are almost twice that in Medicaid populations versus the general population. And also, women with substance use disorders are more likely to have adverse childhood experiences, lower educational attainment, fewer employment opportunities. So that can affect early childhood dynamics and just the early development of the child. So in terms of legality, I think it's really important to identify mothers who may be using or misusing opioids, as testing positive at birth will be reported to CPS. I think we're in a really good position to intervene in the case that there is opioid misuse happening so that we can try to help mom go into recovery and hopefully keep the family unit together if that's the only issue. A first-time possession charge is a Class D felony, which is punishable by up to 3 years in prison in Kentucky. So that can have a negative outcome on the family unit as well. And this just leads to punishment, decreased trust, and increased barriers to care. And most professional bodies are against punishment because of these reasons, and we're really trying to intervene where we can. Okay. So moving on, what is our role in the community? So in terms of primary prevention, we can prevent opioid use disorder by preventing exposure to opioids and increasing protective factors. So by protective factors, assessing for any comorbid mental health disorder, seeing if they have social support, any concerns, things like that. In terms of secondary prevention, It's early identification of opioid use disorder and treatment with evidence-based medicine. So that's what most of this lecture was based on, how we can intervene once opioid use disorder has been identified. And tertiary prevention, reducing negative consequences such as overdose deaths, associated infectious disease, and reduce medical and psychosocial sequelae. So things like prescribing naloxone for patients that are known to have opioid use disorder so that they can use it if needed. And same thing with needle exchange programs so that we're limiting incidences of cellulitis and transmissible infectious diseases. Okay, so now we're at the end of the presentation, and in summary, I just want to say that medication for opioid use disorder is a first-line treatment for opioid use disorder. Buprenorphine has lower risk of adverse fetal outcomes than methadone. There are no significant differences in adverse maternal outcomes. Buprenorphine naloxone is relatively safe and tolerable during pregnancy. It does not necessarily need to be transitioned to buprenorphine only. Breastfeeding is safe and encouraged on medication for opioid use disorder. And long-term neurodevelopmental outcomes are unclear. Methadone has been linked to visual pathway abnormalities. And yep, I think that's it. Are there any questions? Thank you. Sure.
Thank you. I'm sorry I missed the first part of it, but it's a really important subject, and I'm really glad to hear you go through it. And I think the points of all, I totally agree with everything you said, based on my experience, what we know. So here's my question. Feel free, I'll say what I think too, and you comment on it. When the buprenorphine was first coming out, we've had it now for 23 years. But when we were first using it in pregnant women, and we had a real bad problem with neonatal abstinence syndrome. It was really, and the neonatal clinical staff were extremely negative and highly stigmatizing towards patients, particularly when the baby was wide up in the NICU. And there was a really large emphasis on neonatal abstinence syndrome. What the acronym is now, taking myself, that's what I call it. I was never convinced that we had any proof whatsoever that any long-lasting, was associated with any long-lasting problems. Neonatal abstinence syndrome itself was a problem or causing long-term problems with developmentally. That any long-term developmental problems you couldn't tease out because of all the other things that are going on with these patients and what the baby's been exposed to, what the environment is. And so all of a sudden, we were really putting a lot on neonatal abstinence as the problem, and we weren't looking at the big picture. It's a lot better now. There's a lot more education and acceptance of this in the NICU, but it was a big fight for a long time. Anyway, that was my view. I mean, I think the long-term neurodevelopmental outcomes are going to be profoundly affected more by the positive relationship where mom can be a mom and be sober and bond with the baby and be present with motherhood. That makes a huge difference, and that's got to be factored in there. So anyway, the stigma is really bad, and it drives people away from seeking help, and that's the last thing you want pregnant women to do. And Kentucky has been hostile with that, and the laws here. We have to be mindful about that too. Thanks for your talk and comment on the long-term neurodevelopmental outcomes. I like what you brought that up about it. If you want to.
Yeah, so Dr. Stewart asked a question and highlighted some important topics. So the question was, what is the relationship between neonatal opioid withdrawal syndrome and longer-term neurodevelopmental outcome? So the main issue with that, like you acknowledged, was the fact that the presence of neonatal opioid withdrawal syndrome, it is occurring because there is, an opioid medication involved, whether it's buprenorphine or methadone, and sometimes it can even happen with naltrexone. So I would say based on what I've read, they haven't really dug into that just because there's too many confounding factors. So they really just focus on exposure to methadone or exposure to buprenorphine.
It does have another, moms are on fentanyl, they're not treated too, they'll have their babies will go into bed as well. And moms are really worried about this. They really feel bad about it. They get really upset about the baby being in withdrawal, and they think that's what's gonna hurt the baby. And so I think it's always kind of reassuring about that.
No, exactly. And Dr. Stewart also brought up points about, destigmatizing opioid use disorder, really encouraging mom and baby to bond, trying to create a conducive environment for that, and had some great feedback. I hope you all heard it on Zoom. Okay, are there any?
I have a bit of a comment. It's pretty minor. But if you look at the product of Suboxone, the combination of buprenorphine with naloxone, the naloxone was included because of the concept that, well, if you take it orally or sublingually, that the absorption of the naloxone will be low, or if it's swallowed, will have such high first pass metabolism that it won't matter. But if you inject it, you're going to precipitate a withdrawal or prevent the buprenorphine from acting. But in reality, buprenorphine has a much higher affinity for the receptor than naloxone does. And the dose of naloxone is so low in the combination product, it's essentially inert. So the comparing buprenorphine with naloxone versus buprenorphine on its own, they are nearly identical products. They're essentially identical products.
Yes, and I think it goes back to previously, like they just thought that it might be better to expose the fetus, neonate to one product versus two, but you are completely right. The outcomes have been pretty similar between buprenorphine and buprenorphine naloxone. So when we do have a patient that is on the combination product and they're stable on it and they become pregnant, we do recommend risk versus benefits. Pretty much everything in medicine is risk versus benefits. So, does the risk of destabilization on the on buprenorphine only outweigh the potential risk of exposing the baby to two medications instead of just one? And I think you're absolutely correct in terms of the pharmacology component of it, and the outcomes support that. Okay, are there any other questions? Oh, yes.
Thank you, Dr. Ancha, for your wonderful presentation. This last week, I was working on the consult service, and there was some pre-contemplated patient that ended up leaving the hospital. She wasn't started on any treatments, and there was a lot of drama between the nursing and the patient. The nursing was asking about legal ramifications and things like that. What do you suggest we do, like how would you advise nursing staff to help the process of giving a patient?
Yeah, so ultimately, I think being empathetic to the patient, like we talked about motivational interviewing, I know that's not generally thought of as a nursing duty, and that's kind of more as like a physician, specifically a psychiatrist duty. But I think the general tenets apply, just being non-judgmental, being open, really trying to see if they want to be where they're at in their life, and to really just encourage self-esteem to really make that change, to figure out why they haven't made the choice to maybe cut down or stop usage. In terms of having a patient that is actively using substances and ultimately they are not interested in treatment, we can't really do too much legally. We know that it's not a good decision, and I'm sure that the patient themselves are also aware. But yeah, that's probably what I would recommend, just trying to be empathetic, non-judgmental, and really give them the confidence to think about things in a different way, because there's a lot of shame and guilt that goes along with this, and it's just a cycle where you know, if you feel terrible about yourself, you're just going to kind of make terrible decisions because it doesn't matter. Yeah. Mehak?
Thank you for this wonderful talk. I want to ask a question that I was here, how comfortable do you feel in starting something like methadone versus buprenorphine? And also how comfortable do you feel if it's a pregnant patient? You're about to graduate. I want to know how much is the exposure that we get in training for methadone versus buprenorphine and methadone.
Okay, so the question was, how comfortable do I feel prescribing methadone or buprenorphine in a pregnant patient? So personally, I do not have like a specific certification to prescribe methadone. Unfortunately, I have had pretty much zero training in methadone. Formally, we do have patients on methadone where we will increase or decrease dosage based on cravings or side effects that are inpatient. But as an outpatient, I would probably say I personally don't feel comfortable yet because I'm also not specifically trained for that certification. Whereas for buprenorphine or the combination product Suboxone, I feel very comfortable prescribing that in a pregnant patient or in a non-pregnant patient. We get very comfortable with it. Yes. Okay. So I think that's it for all the questions. Thank you so much. I'm happy to present for you all and have a good day.
Yeah, this is Dr. Walker. Just want to thank you for all the work you've done in this presentation. Great job.
Oh, thank you. I appreciate that.